Welcome, I'm Professor Erik van Cutsem from Leuven in Belgium. I'm a GI oncologist and I'm happy to be here at the BGI-CS meeting in Cairo, Egypt. We had a lot of interesting discussions, and for instance, a discussion that we had was on pancreatic cancer, to look at the optimal and to discuss the optimal sequence for patients with metastatic pancreatic cancer. Today the basis is still chemotherapy. In very fit patients we can start with modified FOLFIRINOX or NALIRIFOX or gem-nab-paclitaxel in these patients, and then in second line we can change the treatment chemotherapy to liposomal irinotecan, NALIRI plus 5-FU in those patients who were pre-treated with gem-nab-paclitaxel. But what we discussed especially also in the region here is some new data that will come through. We will see in the near future data on KRAS inhibitors. We had a lot of discussion whether it's going to be allelic specific KRAS inhibitors, for instance G12C, G12D, whether it's going to be second line, whether it's going to be first line, whether it's going to be in combination with chemotherapy and with which backbone. But the reality is that we expect that the upcoming data will change the outcome for patients with metastatic pancreatic cancer. And now we are at median survivals of between 10 and 12 months. We hope and expect that that will be clearly much more. And that will lead to the need, as we discussed also here in Cairo, to do more molecular analysis in patients with pancreatic cancer. The first challenge is to obtain good tumor material, because often we have an endoscopic ultrasonographic biopsy. This is relatively small piece of tissue to do an NGS, but it is possible to do that, and we will have to learn and to work on that. We know that around 90% of patients have a KRAS mutation. We will look whether it's a G12C, G12D or another mutation in this situation. And then for the patients with the KRAS wild-type tumor, we have also some new treatment options based on the molecular analysis. So a low number of these patients have a HER2 positive tumor. Some patients may have a BRAF V600E mutation. Some patients an NRG fusion. Or an NTRK fusion, as just a couple of the examples. So targeted agents are coming also in clinical practice in pancreatic cancer. On top of looking at KRAS analysis, and in those patients with the KRAS wild type, the other alterations, we look also in patients with pancreatic cancer to a germline mutation, HRD, BRCA1 and 2 mutations, because these patients do better with platinum-based chemotherapy, and also maybe potential candidates for PARP inhibition. So the field finally of pancreatic cancer is moving, and we had interesting discussions here at this very, very nice meeting here in Cairo. And I was happy to be here involved and to discuss with the local physicians of the MENA region, because cancer doesn't know any borders. We're moving forward also in the different regions, and that's important. Thank you for listening to me.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.